Welcome to the deep dive. Today we're tackling something pretty fundamental to understanding health, medical research itself.
That's right.
We're going to explore how we figure out, why diseases start, how they spread, and how we evaluate the best ways to diagnose and treat them.
Think of it as getting the story behind the health headlines.
Exactly, the science behind the news.
And you asked us to really delve into the basics of epidemiology and clinical research methods. So that's our focus today.
Yeah, we're drawing on that chapter, Epidemiology and Research Methodology, to sort of unpack how medical professionals gather evidence and decide, well, what works best for patients.
Our mission really is to give you a solid grasp of these core ideas and methods.
Right, so you can feel more empowered when you see health information, understand the basics of where it comes from, without feeling totally lost in the jargon.
Precisely. No overwhelm.
Okay, so let's get into it. Starting with epidemiology,
Yeah.
what is it, really, at its heart?
Well, the name itself kind of gives it away. It's Greek. Epi meaning upon, demos meaning the people, and logos, well, study, so literally the study of what's upon the people.
What affects populations?
Exactly.
Yeah.
But its real job is answering those four key questions in medicine: diagnosis, etiology, that's the causes, treatment, and prognosis, the likely outcomes.
So the whole picture, start to finish. Causes, consequences, how we treat it. And this isn't new, is it, this way of thinking?
Oh, not at all. I mean, you can go way back to Hippocrates thinking about how outside factors affect illness. But a really famous example, a landmark case, is John Snow, London, 1854, the cholera outbreak.
The Broad Street pump, yes.
Yep.
This is where it gets really interesting.
It really is. Snow was incredibly meticulous. He mapped out where the cholera cases were happening, just visually plotted them
On a map.
on a map. And he saw they clustered around this one specific water pump on Broad Street. He figured out the water was contaminated.
And his solution was so direct.
Amazingly so. He convinced the local council to just remove the pump handle.
Just take it off.
Take it off, and boom, the outbreak stopped. It's such a powerful early example of identifying how a disease spreads and intervening effectively.
And it shows, like you said, observation and, well, simple data visualization can be incredibly powerful.
Didn't need fancy computers then.
Not at all. Now, of course, modern epidemiology has built massively on that foundation. We have incredible tools now.
Like what?
Huge international registries pooling data from millions, massive servers crunching numbers. We use machine learning now to find patterns we might miss. Online collaborations connecting researchers instantly across the globe.
Wow. A world away from removing a pump handle.
It is. And yet, the core principles haven't really changed. It still comes down to the quality of your data, having a sound analysis plan, and being able to interpret what you find clearly.
Data quality, solid methods, clear interpretation.
Got it. Okay, so that's epidemiology, studying disease in populations. Let's switch over to clinical research. Generating the evidence itself. It always starts with a question, right?
Always. Every single research project kicks off with a clinical question, something nagging at a doctor or a researcher. Like, why do these vein grafts keep failing after a few years? Or, when is a patient really at high risk for their aneurysm rupturing? And the key thing is, different questions need different ways to find the answers, different study designs.
Makes sense. You wouldn't study a common cold the same way you study, say, heart disease outcomes over decades.
Exactly. The chapter lays out two main categories of study design, broadly speaking.
Okay, what are they?
You've got observational studies and experimental studies.
Observational, like just watching.
Pretty much. Researchers observe what's happening without actually assigning a specific treatment as part of the study. They can look forward in time, that's prospective, or they can look back at data that's already been collected, that's retrospective.
Okay, and experimental.
That's where the researchers do intervene. They actively test something, a new drug, maybe a medical device, or even just a different clinical pathway or process. And these studies, importantly, they can only be prospective. You're testing something going forward.
Right, so observational is looking, experimental is testing. The chapter also brings up prevalence and incidence early on. These sound important for understanding disease frequency.
Oh, they're fundamental. Absolutely. Prevalence tells you how common a disease is in a population at one specific moment in time, like taking a snapshot or a census.
Okay, how many people have it right now?
Exactly. Often useful for diseases people live with for a long time, chronic conditions.
Right, and incidence.
Incidence is different. It's the rate of new cases showing up over a specific period. How many people are newly diagnosed within, say, a year?
Ah, so the rate of new cases.
Yes. Often more useful for shorter-term illnesses or tracking outbreaks.
Okay, prevalence, the snapshot total. Incidence the flow of new cases over time.
Ah.
Got it. Let's dig a bit deeper into those observational studies. Cohort studies are mentioned prominently. What's the basic idea there?
Okay, so imagine you identify a group of people, a cohort, who share some characteristic. Often, in epidemiology, it means they're at risk for developing a certain disease, but they don't have it yet.
Okay, an at-risk group.
Right. You enroll them in the study, and then you just follow them over time, see who develops the disease and who doesn't. Then you compare the characteristics or exposures between those two groups.
And we've seen some big cohort studies in vascular surgery, haven't we? That aneurysm study comparing EVR and open surgery.
Yes, the OVER trial, the Veterans Affairs Cooperative Study Group. That was a major one. They took a large group of veterans needing aneurysm repair and randomly assigned them, though this part actually makes it an RCT, we'll get to that. Assigned them to either EVR, the endovascular approach, or traditional open surgery.
And followed them for a long time.
A very long time. And what was really interesting is that after, I think it was 14 years, the overall survival rates were pretty similar between the two groups.
Wow, that really shows the value of long-term follow-up from these kinds of studies.
Absolutely. It tells you about the durability and long-term impact of treatments.
The chapter also talks about using big registries, like the VQI, linked with Medicare data. How does that kind of large-scale data help?
Oh, it's incredibly powerful. Linking clinical registries like the Vascular Quality Initiative, which collects detailed procedural data, with administrative databases like Medicare claims, which track long-term events like rehospitalizations or death, lets you study outcomes in huge numbers of patients. Real-world patients.
So not just trial patients.
Exactly. For instance, one study used this linked data for almost 13,000 EVR patients. They found about a third were actually at risk for needing another procedure down the line.
A third. That's significant.
It is. And importantly, they could pinpoint 5 specific clinical factors present right at the time of the first repair that were linked to this higher risk of reintervention.
That's super useful for doctors, right? Knowing who needs closer watching.
Precisely. It helps tailor follow-up care, more personalized medicine.
Okay, but what if the condition is really rare? You might not find enough patients in one registry or even one country.
That's where collaboration is absolutely key. The chapter mentions the UCLA Vascular Low-Frequency Disease Consortium.
Right, pooling data.
Exactly. They bring together data from, I think, 75 institutions worldwide. This allows them to gather enough cases to actually study rare things like renal artery aneurysms or, say, infections developing in aortic stent grafts. It shows the power of working together for these uncommon conditions.
Strength in numbers,
Wow.
literally.
Yeah.
There was also mention of a single institution study looking back at vascular resection during sarcoma surgery. How does that fit in?
Sometimes, for a very specific, maybe complex or unusual procedure, a deep dive into one hospital's experience over many years can yield really valuable insights, too.
A focused look.
Right. In that sarcoma study, they looked back retrospectively over 14 years at about 50 patients who had this major vascular resection as part of their cancer surgery. Then they compared them carefully to about 100 similar sarcoma patients who didn't need the vascular part. It allows for a really detailed analysis of that specific high-risk procedure in that specific context.
So, big cohorts, multi-center collaborations, focused single-center analyses. Observational studies give us a lot of different angles, and they help identify risk factors too.
Definitely. By comparing those who develop a disease within the cohort to those who don't, you can look for factors, exposures, characteristics that are more common in the group that got sick.
And calculate things like odds ratios.
Exactly. Especially in retrospective studies like case control designs or sometimes within cohort analyses, the odds ratio gives you a measure of how strongly a particular factor is associated with the disease.
And the Vascular Study Group of Northern New England did something like this for aneurysm repair outcomes.
Yes, they followed a cohort of patients having elective EVAR, or open repair, and looked prospectively at factors linked to dying within the first year.
And what did they find?
They identified several specific patient factors associated with higher one-year mortality. This kind of information is vital. It helps doctors stratify risk better, have more informed conversations with patients, and potentially choose the safest approach for that individual. It directly impacts patient selection.
Okay, so observational studies are crucial for watching, learning, identifying risks. But when you want to definitively test if a treatment works, that's where experimental studies, especially RCTs, come in.
You got it. Experimental studies mean we, the researchers, introduce the exposure or treatment we're interested in. And the randomized controlled trial, the RCT, is really a cornerstone method here.
The gold standard, people often say.
Yeah.
Why is that randomization part so critical?
Its power is really in minimizing bias. When you randomly assign participants to either get the new treatment or get the standard treatment or placebo, you're essentially trying to make the groups as similar as possible in every way except for the treatment itself.
So it evens out all the other factors, known and unknown.
That's the goal. If the randomization works well, any difference you see in outcomes at the end is much more likely to be actually due to the treatment, not because one group was maybe sicker or younger or had some other underlying difference to begin with. It means you often need less complex statistical gymnastics later to try and adjust for those potential confounding factors.
The chapter mentions different ways to randomize, though. Complete, block, adaptive, cluster. Why so many types?
Well, each has its place depending on the study's needs. Complete randomization is simple, like flipping a coin for each person. Block randomization helps make sure the group sizes stay roughly balanced as the trial progresses. Adaptive randomization is interesting. It can actually change the probability of assignment based on how things are going in the trial. Maybe if one treatment looks really promising early on, you might slightly favor assigning more people to it.
Dynamic.
And cluster randomization is different again. Instead of randomizing individuals, you randomize whole groups or clusters, like all the patients in one clinic or one hospital.
Like that Prove-V-Bibele trial example.
Yeah.
Randomizing based on location for using a decision aid.
Exactly. That's a perfect example. They randomized locations to either use the decision aid or not. Why? Because if they randomized individual patients within the same clinic, there was a risk of contamination, meaning a surgeon treating one patient with the aid might subconsciously change how they talk to their next patient who wasn't supposed to get it. Randomizing by cluster, by location in this case, helped prevent the surgeon's behavior for one group influencing the other. It shows how researchers really think hard about the best way to randomize to avoid specific biases.
That makes a lot of sense. Now, ethics must be huge with experimental trials, right? You're actively giving people different treatments.
Absolutely paramount. The bedrock ethical principle is clinical equipoise.
Equipoise.
Yeah, it means there has to be genuine uncertainty within the expert medical community about which treatment is better. If everyone already knows treatment A is superior to treatment B, you cannot ethically randomize patients to treatment B.
The parachute analogy in the chapter.
Exactly. You wouldn't do an RCT of jumping out of a plane with versus without a parachute. The evidence is kind of already in on that one. There's no equipoise.
All right, clear case. But even with equipoise, RCTs aren't always easy to do, are they? The chapter lists quite a few challenges.
Oh, definitely not. They can be incredibly difficult. Sometimes they're just impractical or maybe even impossible for ethical or logistical reasons. They are almost always very expensive and time-consuming.
And getting patients to enroll.
That can be a huge hurdle. Patients might have strong preferences. Doctors might have biases. Recruitment can be slow. Then you have issues like patients dropping out, or maybe switching from the control group to the treatment group later on. That's called a crossover.
And do the results always apply to everyone?
That's another challenge, generalizability. RCTs are often done in specialized academic centers with expert teams and carefully selected patients. The results might not perfectly reflect what would happen in a typical community hospital with a broader range of patients.
And you could miscalculate how many people you need.
Yes, inaccurate power calculations. If you underestimate the sample size needed, your study might not be powered enough to detect a real difference. Even if one exists, you might get a false negative result.
So lots of potential pitfalls. What about those single-arm trials using historical controls? When are they used?
They're sometimes used as an alternative when a full RCT is just too difficult. You give everyone the new treatment, that's the single arm, and compare their outcomes to a similar group of patients treated in the past with the old standard, the historical controls.
But that sounds less robust.
It generally is. It's much more prone to bias because the groups weren't treated concurrently. Medical care changes over time, patient populations might shift. Lots of things could be different between the current group and the historical group, besides just the treatment itself. So it's seen as weaker evidence than an RCT.
Okay, observational, experimental. Now, meta-analysis, this sounds like combining studies.
That's exactly what it is. Meta-analysis is a statistical technique. You take multiple separate studies that all looked at basically the same research question, and you pool their results together.
Why do that? What's the benefit?
Well, several benefits. By combining data, you decrease the random error or sampling error that exists in any single study. You usually end up with a more precise estimate of the overall effect. And crucially, you increase the statistical power, your ability to detect a true effect if it's there.
So a stronger, clearer signal by combining forces. What do you need for a good meta-analysis?
The most critical thing is that the studies you combine need to be looking at a common outcome, a common dependent variable. They need to be similar enough in terms of the question they asked.
Apples to apples, sort of.
Kinda, yeah. Then you calculate an effect size for each study, basically. How big was the treatment effect found in that study? And then you combine these effect sizes, but you don't just average them, you weight them.
Weight them. How?
Usually based on their precision. Studies with less variability around their result, often larger studies, get more weight in the final combined estimate. Their results are considered more reliable.
Okay, that makes sense. Give more influence to the more precise studies. What about heterogeneity? That sounds important.
Very important. Heterogeneity refers to how much the results vary between the individual studies you're pooling. Are they all finding pretty similar effects, or are the results all over the place?
And how do you deal with that? Fixed versus random effects models.
Right. So a fixed effects model basically assumes all the studies are estimating the exact same underlying true effect, and any differences are just random chance within each study. It focuses on within-study variance.
Okay.
A random effects model is often considered more realistic. It assumes the true effect might actually vary somewhat from study to study, maybe due to differences in the patient populations or how the treatment was given, etc. So it accounts for both the within-study variance and the between-study variance.
Got it. And visually, we see these results in a forest plot.
Yep, the forest plot is the classic way to display meta-analysis results. You see each individual study's result, usually a point estimate like a square, with its confidence interval aligned through it. The size of the square often shows the study's weight.
And then the combined result.
Usually shown as a diamond at the bottom. The width of the diamond shows the confidence interval for the overall pooled estimate. The chapter had that example on aspirin and non-cardiac surgery, which illustrates it well.
And you can include observational studies sometimes. And what about publication bias? That sounds worrying.
Yes, you can include observational studies, though traditionally RCTs were preferred. Including observational studies often increases heterogeneity because they tend to have more potential biases, and publication bias. Yeah, that's a major concern.
What is it exactly?
It's the phenomenon where studies with positive or statistically significant results are just much more likely to get published than studies with negative or null result studies that found no effect.
So the published literature might be skewed towards positive findings.
Exactly. All those studies sitting in file drawers because they didn't find anything exciting could mean the overall picture we see from published meta-analyses is overly optimistic.
How do you even check for that?
There are tools. Funnel plots are common. You plot each study's effect size against its precision. If there's no publication bias, it should look roughly like a symmetrical inverted funnel.
And if it's skewed?
If it's asymmetrical, maybe missing studies in one corner, often the small studies with non-significant results, it suggests publication bias might be present. There are also statistical tests like Begg's test and Egger's test that try to quantify this asymmetry.
Wow. Meta-analysis seems powerful, but also needs careful handling.
Yeah.
Okay, so we've gathered data, maybe even combined studies. Now, outcomes analysis, making sense of it all.
Precisely. This is where we try to figure out causation, did the treatment cause the outcome, and how broadly we can apply our findings. And always remembering there's uncertainty because we studied a sample, not everyone.
And bias is a huge theme here again.
Yeah.
Systematic error. Can you recap the main types?
Sure. Bias is error that pushes results consistently in one direction. We mentioned selection bias differences between who gets in the study versus who doesn't, related to the outcome.
Like healthier people volunteering.
Or sicker people being more likely to be recruited for certain studies, yeah? Then there's information bias, systematic errors in how data about exposure or outcome is collected. Maybe people misremember things or measurements aren't consistent.
Okay.
And confounding, which we touched on, that hidden third variable linked to both the exposure and the outcome, messing up the apparent relationship, like the race, ethnicity, and limb ischemia example, where diabetes might be the real driver.
Right.
And a specific type in observational studies is confounding by indication. Sicker patients might be more likely to get a certain treatment, so the treatment then looks like it leads to worse outcomes, but it was just that the patients were sicker to start with.
That seems tricky to untangle. How do researchers fight confounding?
Several ways. In experimental studies, randomization is the best weapon. In observational studies, you can try matching cases and controls on potential confounders. You can stratify your analysis, look at results within subgroups, e.g. diabetics versus non-diabetics separately, or use multivariate statistical analysis to mathematically adjust for the influence of confounding variables.
Which brings us to the stats tools. Descriptive stats, hypothesis testing.
Right. Descriptive stats just describe your sample, means, medians, percentages, who is in the study. Hypothesis testing is the formal process of seeing if an observed difference is likely real or just due to chance, using p-values and significance levels.
And regression analysis and survival analysis seem like workhorses in this field.
They really are. Regression analysis lets us model relationships. How does variable X affect outcome Y, potentially while controlling for other factors? Z, linear regression for continuous outcomes, logistic regression for yes-no outcomes. The coefficients tell you the strength and direction of the relationship. R squared tells you how much variation your model explains.
And survival analysis for time to event data.
Exactly. Things like time until death, time until a graft fails, time until cancer recurs. It's specifically designed to handle time and also censoring.
Censoring.
That's when you lose track of someone before the event happens, or the study ends before they have the event. Survival analysis correctly incorporates that information. The Kaplan-Meier method is very common. It creates those stepwise survival curves you often see.
Right, the curves showing the proportion surviving over time.
Yep. And you can compare curves between groups using tests like the log rank test. Cox proportional hazards models then let you do multivariate survival analysis, looking at how multiple factors influence survival time simultaneously.
And what about those other techniques mentioned for non-randomized studies? Propensity scores, instrumental variables, trying to mimic randomization.
Kinda, yeah. Propensity scoring is a statistical fix for observational studies. You calculate the probability, or propensity, for each person to have received the treatment based on their observed characteristics. Then you use that score to match patients between the treated and untreated groups, or adjust for it statistically, trying to make the groups more comparable.
But it only counts for things you measured, right?
That's the key limitation. It can only balance the known, measured confounders, unlike randomization, which tends to balance the unknown ones too. Instrumental variables is a more complex method, trying to find some factor, the instrument, that influences treatment choice but doesn't directly affect the outcome itself except via the treatment. It's clever but relies on finding a good instrument, which can be hard. Both are useful attempts to get closer to causal inference without an RCT, but RCTs remain stronger.
And we always have to worry about making errors in our conclusions, type I and type 2.
The two big statistical errors. Type I error alpha is a false positive. You conclude there is a difference when there really isn't, like a false alarm. We usually set alpha low, like 0.05, meaning a 5% risk.
Yeah.
Type 2 error, beta, is a false negative. You conclude there's no difference when there actually is one, like missing a real signal. Power 1 beta is the probability of avoiding a type 2 error, of detecting a real difference if it exists. Power is heavily influenced by sample size. Bigger studies have more power.
So a trade-off between false alarms and missed signals. Then there's utility measures, decision analysis, cost effectiveness, bringing in values and costs.
Exactly. Utility measures try to quantify how much people value different health states being perfectly healthy versus living with symptoms, for instance. Tools like the EQ5D or methods like Standard Gamble help measure this.
And that feeds into
Decision analysis. This uses decision trees to map out choices, potential outcomes, their probabilities, and their values, utilities. It helps find the strategy expected to yield the best overall outcome, considering both likelihood and preference. Sensitivity analysis checks how robust the decision is if those probabilities or values change a bit.
And cost effectiveness ties it to resources.
Yes. Cost-effectiveness analysis compares treatments based on their cost per unit of health gain, often dollars per QLOY quality-adjusted life year gained. Cost-benefit analysis tries to put monetary values on everything, both costs and benefits. These help society decide how to allocate healthcare budgets efficiently.
So all this research, all this analysis, it eventually shapes actual medical practice through evidence-based medicine.
That's the goal. Evidence-based medicine is about integrating the best available research evidence with individual clinical expertise and patient values. It's not just following the studies, and it's not just relying on experience, it's blending them.
And those levels of evidence tables help.
They do. They provide a hierarchy. Systematic reviews of high-quality RCTs are typically at the top. Level 1 evidence, then maybe individual RCTs, then good cohort studies, and so on. Grades of recommendation, like grade A, B, C, then suggest how strongly a guideline or practice is supported based on the level and quality of that evidence.
So it provides a framework for saying this recommendation is based on really strong science. Okay, finally, looking ahead, what's next for vascular outcomes research?
Well, there's always more to do. A continuing need to better understand long-term results, technical success, sure, but also vessel patency, treatment durability over many, many years.
Beyond just the immediate fix.
Right. And measuring outcomes more broadly, quality of life, return to work, patient-reported outcomes. Collaboration is key here, too, across academia, industry, government agencies. The Vision Network is mentioned as an example, coordinating efforts to track vascular device outcomes long-term.
So more data, more collaboration.
That seems to be the direction. The future really relies on these coordinated, multi-institutional approaches to generate the robust data needed for complex trials and ultimately to keep improving how we care for patients with vascular disease.
Well, we have certainly covered a lot of ground today on epidemiology and clinical research. We've gone from the basics of studying disease in populations through all the different ways we design studies, the stats we use to make sense of the data, and how it all feeds into practice. Hopefully, you now have a clearer picture of things like cohort studies, RCTs, bias, randomization, meta-analysis, the building blocks of medical evidence.
Yeah, the goal was really to give you that framework. So when you encounter health information, maybe you can approach it with a more informed, maybe slightly more critical eye, feeling a bit more confident about what's behind those recommendations.
Okay, so here's a final thought for you to chew on. We talked about those hierarchies of evidence, RCTs at the top, other studies below. How might knowing the level of evidence behind a particular treatment influence your own decisions if you were facing a health choice? Or how might it affect the policies that shape healthcare for everyone? What questions does that raise for you about how medical knowledge keeps evolving? Something to think about. Thanks for joining us for this deep dive.